Hello and welcome to this educational webinar series, Prenatal Genetic Screening Decoded, a masterclass series for healthcare professionals. In this series, we'll be looking at selected topics that form an important part of the use of prenatal genetic screening. Our goal is to help healthcare providers to access a deeper understanding of these topics in order to support the provision of the best care to patients who are considering or undergoing prenatal genetic screening. My name is Dr. Samantha Leonard, and I'm the Senior International Medical Director for Women's Health at Natera. For the second webinar in this series, we're looking at the issue of the genome-wide approach to NIPT, the types of findings that can be uncovered, and the impact of this approach as a general screening test. I'm delighted to have with me Dr. Peter Benn. For the past 25 years, he's been a faculty member at the University of Connecticut Health Center and is currently Professor Emeritus in the Department of Genetics and Genome Sciences. Dr. Benn chaired the International Society for Prenatal Diagnosis's Special Interest Group for Prenatal Screening. He's also chaired the ISPD's Committee for Chromosome Abnormality Screening, which developed position statements for non-invasive prenatal screening. Thank you, Dr. Benn. Over to you.
Thank you, Samantha, for the introduction. Today's topic is genome-wide non-invasive prenatal testing using cell-free DNA. And in this talk, what I'm going to do is, first of all, define what genome-wide NIPT is. I'm going to discuss the frequency and the usually uncertain, nearly always uncertain significance of these findings. Consider the impact of the use of genome-wide NIPT as a general screening test. And then I'm going to summarize some key professional guidelines that have recently been issued that address this particular topic. So let me begin by talking about the definition of a genome-wide non-invasive prenatal test. And this is usually defined as being a test that will detect any large chromosome imbalance. And usually the threshold that's set is about 7 megabases of DNA. So that's the equivalent of about 1 chromosome band. So that excludes a lot of things. It excludes most of the things that we detect with a chromosome microarray that we refer to as a small copy number variant, a microdeletion, or a microduplication. It also excludes many of the very specific microdeletion syndromes, such as 22q11.2 deletion, which typically are substantially smaller than 7 megabases. What it does include are what we refer to as rare autosomal trisomies, or RATs, and these are the trisomies other than 21, 18, and 13, so those are the so-called common autosomal trisomies, and it also includes some rare autosomal monosomies, which sometimes gets abbreviated to RAMs. It also includes parts of chromosomes, so that's deletions and duplications, unbalanced translocations, what we used to refer to as marker chromosomes sometimes when we couldn't figure out what they were. But the whole idea is that it's based on a relatively low depth of sequencing. And this is an important point. It is only detecting these larger chromosome segments, and it really shouldn't be confused with high-depth sequencing that's used for exome sequencing and identifying very specific genomic events, point mutations, or small duplications or deletions, which are pathogenic for very specific syndromes. So genome-wide NIPT, large chromosome abnormalities, and it has been routinely available in Belgium and Netherlands, and it has been used somewhat elsewhere. So what happens if we apply a genome-wide NIPT test. And I'm not going to talk about sex chromosome abnormalities today. I'm just going to talk about the things that are picked up by this genome-wide NIPT. And I'm going to cross-reference that to the things we do know about, which is trisomy 21, 18, and 13. So if you apply NIPT for chromosomes 21, 18, and 13, as you know, these tests are pretty good. They've got very high positive predictive values. And if you take a total population, what you can expect, this is based on some Belgian data, you can expect about 0.32% of the cases to be positive for trisomy 21, about 0.07% trisomy 18, and about 0.06% positive for trisomy 13. So these are positive tests. They're not actual abnormalities detected. If you decide you're going to do a genome-wide NIPT, you're going to pick up these additional things that are in red on this slide. So you're going to pick up rare autosomal trisomies and monosomies, and that's going to constitute about 0.23% of your tests. You're going to pick up some fetal structural abnormalities, so chromosome imbalances in the fetus, and you're going to pick up quite a lot of maternal chromosome abnormalities, copy number variants, about 0.32% of those. And then also you're going to pick up a very few number of cases with a very complicated chromosome complement that could be possibly associated with maternal cancer. So if you add up all these three red frequencies, what you're going to be doing is roughly doubling the number of tests that are positive. Now, again, I'm emphasizing that you're not picking up twice as many abnormalities. You're picking up twice as many positive tests that will need follow-up testing. So now I'm going to talk a little bit more detail about each of these specific groups of abnormalities, and I'm going to start with the rare autosomal trisomies and monosomies. So as I said a moment ago, this is going to be about 0.23% of the positive tests. A very small proportion of them, and this is going to depend on the gestational age, will be non-mosaic trisomies or monosomies, and these cases are invariably associated with fetal death. So very often some of these cases get picked up. You go back to the patient and the patient is no longer pregnant. That's quite a common scenario for the non-mosaic cases. Most of these cases spontaneously abort early, so it is a little dependent, as I say, on the gestational age, how often this arises. And then the vast majority of them, though, certainly at the time that we're doing most of the screening, are mosaic abnormalities. And there is a very specific set of chromosomes that tend to be involved. So that's illustrated on the right-hand side of this slide, where you can see that chromosome 7 is the most frequently encountered, but we also see a lot of the other chromosomes here. Most chromosomes can be involved to some degree or another, but sometimes extremely rarely. And the blue bars represent how often these actually are encountered, and the small amber tips on some of the chromosomes that you can see are the cases where you actually end up confirming them if you do a follow-up amniocentesis. So nearly all of these cases don't get confirmed at amniocentesis. It's only about 4% or so that actually have a confirmation. So the positive predictive value when you encounter one of these is about 4%. So this spectrum of chromosome abnormalities that you see here is very reminiscent of what we used to, for many years, see in chorionic villi sampling. If you do a direct preparation, sometimes you picked up rare autosomal trisomies. they were always a headache in CVS. And because we weren't doing very large numbers of cases, there's been a continued controversy about their significance in CVS. Because of the use in NIPT, we actually now have a lot more information about these, and we know a lot more about the significance. One thing we can say about the CVS data is that if it involved chromosome 16, then that was important. That was well established early on as being clinically significant. But for all of the other chromosomes, there's been a continued controversy, and in particular, whether or not they're associated with pregnancy complications. But recent data from genome-wide NIPT has actually answered that question, and that's shown in this slide here, where in a study from the Netherlands, they've looked at very large numbers of cases because they were offering this test routinely, and they did collect outcome information. And what you can see on this slide is that for pregnancy complications, there is an increased relative risk here for the complications. The one for preeclampsia looks pretty impressive with an 18.5% relative risk, but as the authors pointed out, they almost certainly under-ascertained preeclampsia in the controls, because instead of being 0.5%, it probably should have been something like 3 to 5% in the controls. So if you adjusted that figure downwards, you'd again be down to something like maybe a relative risk factor of 2 or so. So very weak association with poor pregnancy outcomes if there's a rat present. And we can also take their data and actually back calculate take out chromosome 16 that we know about. And if we do that, we end up with the relative risk figures that I'm showing in this right-hand column over here. And you can see that there may be something going on. They're all slightly more than 1. But in terms of being able to detect and making this a useful test for pregnancy complications, it's certainly not that. There's just enough there to start worrying about without having a very good handle on which chromosome it is and which ones we really should be worrying about and which complication of pregnancy we need to be concerned about. So that's one aspect of rats that's very, very difficult. Most of them are not going to be confirmed. Most of them are maybe only weakly associated with pregnancy complications. There's other things we have to worry about, and one of them is so-called uniparental disomy. So uniparental disomy refers to the fact that sometimes you can have 2 chromosomes that came from one parent and none from the other. So the basic idea here is that you start out with a trisomic pregnancy. You've got 2 chromosomes from one parent, usually the mother, 1 chromosome from the other parent, the father, and then you lose a chromosome. And in theory, 1/3 of the time, that could be that paternal chromosome, and now you're left with 2 copies from the mother, and that's then referred to as a uniparental disomy. So if that involves chromosomes 6, 7, 11, 14, 15, or 20, we know that that can be associated with a so-called imprinting genetic disorder. The genes are expressed differently on the 2 chromosomes in the normal situation, and that can be associated with a distinct phenotype for each of these. So if it involves one of these chromosomes, you need to do an invasive test, you need to rule out uniparental disomy. And we're not done yet, because for the other chromosomes, there's still a concern. You could, for example, express a monogenic disorder, an autosomal recessive disorder that ordinarily would only have been present on one of the chromosomes of one of the parents, and the individual ordinarily would be a carrier, but because of the uniparental disomy, you need to be thinking about whether or not you might have the expression of that recessive disorder. So you need to be thinking about, is there any family history of any genetic disorders? Have you done a universal or expanded carrier screening? And was the patient a carrier for any, or the father a carrier for any of these, for anything on any of the chromosomes that may be involved? So very careful evaluation here is required for these cases. And now we can turn to the next category here, which is the fetal chromosome structural abnormalities. So if you have a chromosome rearrangement, for example, in a parent, it could be segregating as an unbalanced karyotype, or it could be de novo. Generally, these types of chromosome abnormalities are pretty rare. If you take a population at birth, it's estimated that maybe it's somewhere in the region of 0.06%, or a little bit over 1 in 2,000 cases would have a chromosome structural abnormality and an imbalance of this type. It's a bit higher in the second trimester, 0.11%, and a bit higher still in the first trimester because some of these imbalances are non-viable. So we're dealing here with a very heterogeneous group of imbalances, and it also includes some marker chromosomes which segregate in families or don't seem to involve anything that really has a consequence to the phenotype, but are just segregating through a family. So the results for genome-wide NIPT suggest that about 0.07% of the cases will be positive for a structural abnormality. But again, here we don't necessarily find that this is diagnostic. On the contrary, about less than half of them will actually turn out to be true positive results. Some of them will have two or more imbalances, so that would be consistent with an unbalanced translocation where two segments of chromosomes are abnormal. Some of them, many of them, just show a single segment that's apparently unbalanced. But when you get a positive result for one of these, the confirmation studies need to be microarray. It shouldn't be a karyotype because karyotyping does not necessarily pick up some of the smaller imbalances that are associated with translocations. The test also picks up a lot of maternal chromosome abnormalities. That was the biggest single red bar that I showed you earlier on. And you pick up quite a few of these because what happens is that the majority of the DNA in the cell-free DNA is actually maternal. That means you can actually pick up things that are smaller than that 7 megabases of DNA. And now you're into another great difficulty, and that is that if you pick up a maternal abnormality, and it's a relatively benign, a very benign type of significance, there's about a 50% chance that the fetus will also inherit that same chromosome, but it's exceedingly difficult to now identify the fetal status when you've already established that the abnormality is present in most of the DNA that's in your sample, which is the maternal component. So what are these chromosome abnormalities that you're picking up in mothers? Well, they're a heterogeneous group. They could be deletions or imbalances that are associated with cancer or other conditions where the mother's not affected, but it does affect risks for other disorders for the future. It picks up quite a few deletions in the DMD gene because this is a very, very large gene that oftentimes does have segments that are deleted or duplicated. So the mother could have a phenotype, usually not. Fetus could be affected. Need to follow up with an invasive test to sort that out. And then there are maternal chromosome abnormalities that are somatic in nature, and this includes some that are associated with cancers or risks for hematological disorders. Some of these are, for example, deletions of part of chromosome 20q and 5q. These are quite commonly picked up in maternal blood samples or bone marrows from patients with myeloid disorders, but ascertaining them through NIPT is not very well established, and we really don't know what the clinical significance of this is when you find them serendipitously in this way. And then there are many CNVs that are going to be of no known clinical significance that you pick up. So many of these maternal chromosome abnormalities could be picked up outside of pregnancy if you so chose to do the testing, but that's not what is done. These are being picked up as part of a secondary result through the NIPT, and it's at that point that you have to start figuring out what these mean. So I'm often asked, are there special situations that arise where I could see using a genome-wide NIPT? Are there any advantages for specific patients? So I just want to go through a few of these and talk about where genome-wide NIPT might or might not be indicated. So the first thing that people ask me about most commonly would be cases with abnormalities on ultrasound. And the answer here is quite definitely that you really need an invasive test when there's abnormalities of ultrasound. And the reason is because you need to be able to not only look for gross chromosome abnormalities, you need to look at the smaller things, which only the microarray will do on an invasive test sample. And if that's negative, you need to be thinking about exome sequencing and a full range of things that you can do with an invasive test sample that you cannot do with the NIPT sample. So the NIPT sample is not going to be diagnostic, and you still need that invasive test when there's an abnormality on ultrasound. What about cases where there's a balanced translocation in a parent? You know it's segregating. Would genome-wide NIPT be able to tell you whether you've got the unbalanced translocation and safe doing an amniocentesis? Well, many of the reciprocal translocations that do exist have a segment that can be very small, and it may not actually be absolutely identical in the parent and the child. So the strong indication here is these are high-risk cases when there's a balanced translocation segregating, and you really, again, should be thinking about an invasive test with a chromosome microarray to better sort out these cases. What about cases where you've done a CVS, you've seen a confined placental mosaicism on the CVS? Is there any role now for doing an NIPT test? And the answer again here really is no, because you've already established that there's some chromosome abnormality going on, probably just in the placenta, and that doing looking again at the placenta, which is basically what you're doing when you're doing an NIPT test, is really not going to give you any additional information. It's an amnio that's indicated as a follow-up in that situation. What about cases where there's a fetal death? You think maybe it was chromosomally abnormal and you don't have a sample to send as a product of conception to evaluate whether or not there was a chromosome abnormality. So there's a little bit of a few studies that have done this. The success rate is not high because oftentimes there's not enough residual DNA in the maternal plasma for a successful test. So there's really not much data on this. And it's also worth pointing out that an analysis of a product of conception will actually get you some things that a genome-wide NIPT won't get you, and that includes triploidy, which is quite important to identify as a cause of a product of a pregnancy loss. And then finally, one which is kind of interesting, it's rare at the moment, but it's coming up more and more often, and that is that patients, more and more patients who are receiving pre-implantation genetic testing are accepting as a last result, if you like, an embryo that was known to be mosaic based on the pre-implantation genetic testing, and those patients are very, very reluctant to have invasive testing. And the question is, would it be worthwhile doing a genome-wide NIPT to detect the abnormality or rule it out later on? So the answer here is that, well, maybe the genome-wide will confirm that you've still got mosaicism in the placenta, but that doesn't mean much. You already knew that you had it. You already have a situation where the pregnancy needs closer monitoring. So really, either a positive or a negative result is not going to really make much difference or alter the risk. So let me turn now to guidelines and key opinions. There's been several which have been issued in the last year, which really help us a little bit with this whole area. And here's the current situation for professional recommendations for genome-wide NIPT. Originally, ACOG and Society of Maternal Fetal Medicine had guidelines for this. They didn't endorse doing this testing. Their guidance has currently been removed, and they currently are not providing any guidance. That's still under review with those two organizations. But in the last year, we've got new guidance from the American College of Medical Genetics, and their conclusion is insufficient evidence to recommend or not recommend NIPS, non-invasive prenatal screening, for the identification of copy number variants other than 22q11.2 deletions, which they do endorse, or testing for rare autosomal trisomers. ISPD has very recently issued some additional new guidance, and their conclusion is there is insufficient data to assess the performance and clinical utility of routine NIPT for rats or for subchromosomal imbalances. And then very recently also the Health Council for Netherlands has issued new guidance. Now theirs is particularly interesting here because they were the ones that really had a major national program looking at genome-wide NIPT. And their most recent guidance is that they only want to screen for severe chromosome abnormalities. Rats can no longer be reported in the national screening program. So they've withdrawn the routine provision of information for rare autosomal trisomers, but they do still look for other chromosome imbalances. So let me just summarize the things that I've been saying today. Genome-wide NIPT does not detect all the abnormalities detectable by chromosome microarray or exome sequencing. It's not a replacement for those tests. off-target findings, and by that I mean things that are not trisomy 21, 18, 13, and the sex chromosome abnormalities, are going to be very common if you offer this testing, and you really need to think about them as being anticipated. In other words, there's quite a good chance that the test is going to come back positive for one of these things. And because it's anticipated, you really do need to have a more extensive discussion in pre-test counseling, discuss the fact you may be detecting maternal and fetal things that may need a lot of follow-up testing, and that there will be uncertainty associated with this. It's appropriate to say that even for any NIPT test, but really it's not a big issue. The number of times that you get an unexpected finding for a targeted type of NIPT is relatively low, and it's not necessary to spend a lot of time thinking about all of the different scenarios. But for a genome-wide NIPT, we really do need to be saying much more about what the scope of the test is. Genome-wide NIPT will pick up a few additional fetal and maternal abnormalities, but the vast majority of these results are going to be things where there's going to be a need for a lot of additional testing and uncertainty. And many of these results are going to remain sources of anxiety throughout pregnancy, where they're not going to be totally resolved. And in some cases, beyond pregnancy, there will never be a complete answer for some of these. For a genome-wide NIPT, you do need to take into consideration some maternal health factors, and for some of the results, you will need to be thinking about all of the follow-up that might be associated with a diagnosis of possible cancer. And finally, my final point was that genome-wide NIPT lacks the full clinical validation, and it's currently not endorsed by ACOG, ACMG, or ISPD. So thank you. I will now turn this back to Samantha. Thank you.
Thank you very much, Dr. Benn, for that extremely interesting and enlightening talk. And I'd like to turn now to some questions, and to remind the audience that if you have some questions, please do go ahead and put these in the question tab that you'll see. So we have a few questions, including some that came in during the registration process. So we'll get started with those. So the first question is, what is the role of whole genome sequencing on NIPT in women who have advanced maternal age?
Good morning, and thank you for that question. I'm actually glad that you've asked this particular question, because it gives me an opportunity to re-review some of the terminology here, which is really quite confusing. The question was about whole genome sequencing, and usually that term refers to sequencing both introns and exons. And it is available, but it's currently extremely expensive, and it's really not routine. It would really be more of a research tool, and it is a technology that's emerging, but it's not there yet. And part of the problem is that you get a lot of results which are really very difficult to interpret, as well as the cost. So because of that, people oftentimes will use exome sequencing. So that is really only sequencing the parts of genes that are coding. Again, it's still quite expensive. So because it's expensive, it's really only carried out as a secondary test rather than a primary test. And again, there will be cases that are difficult to interpret, and generally exome sequencing is only carried out in the prenatal context on embryo or CVS samples where there is abnormality, where you can really justify this additional testing. But it is more practical and economical to do that as a follow-up test. So really, we also need to be thinking about these tests as alternatives in the context of invasive testing. For carrier screening, that's really based on cell-free DNA at this time, and that is a low-depth sequencing that gives you limited information, usually for the common trisomy sex chromosome abnormalities, 22q deletions, but not for everything.
Great, thank you very much. Next question is that in a low-risk population, what test would you recommend, basic or extended, or would you consider to offer first trimester screening?
So I personally would recommend screening by NIPT for trisomy 21, trisomy 13, trisomy 18, sex chromosome abnormalities, and the 22q11.2 deletion syndromes. Many centers no longer offer first trimester screening markers. Some centers do still measure nuchal translucency, and that can be valuable because it does pick up abnormalities that none of these NIPT approaches can detect. This varies a lot from center to center. Some people feel very strongly that nuchal translucency measurement is still very important. In some places, this is restricted because of the economics, the costs of the testing. So you're allowed to provide either NIPT or conventional, but not both. So this varies from center to center. Generally, the best screening is through NIPT, the highest yields, much greater than the traditional first trimester screening tests with serum markers. So that's the way to go as a primary test.
Great, thank you. The next question refers back to one of the things that you mentioned earlier, chromosome translocations. So the question is, I have a patient who has a chromosome translocation, and there is therefore a concern about an unbalanced carrier type in the fetus. This is a carrier parent, presumably, who's worried about their fetus, and the patient is adamant that she does not want CVS or amnio. The ultrasound looks normal, but it's only 12 weeks. Should I send a sample for a genome-wide NIPT?
Yeah, so this comes up quite a bit, and a lot of patients are very strongly opposed to receiving an amniocentesis, even though we would say that that would be really the optimal test to do in this situation. I would say that for this scenario, the best thing to do is to talk to a genetic counselor or a clinical geneticist who can really evaluate that particular translocation that was identified in the patient. And the reason I say that is because some of these translocations, actually quite a few of them, do involve fairly small segments of the chromosome, and you really wouldn't expect NIPT to be very efficient at being able to identify those small imbalances. Although they're small imbalances, they're still clinically very, very important. They do lead to abnormal phenotypes, sometimes quite severe. Severity is not necessarily related to the size of the portion. Others are going to be larger segments, and maybe you could identify them by NIPT. Many of the larger ones, though, will be associated with an abnormal ultrasound or maybe a loss. So the best way to sort through all of this and to really manage this patient is through a genetic expert, counselor, or clinical geneticist.
Thank you. Thank you for explaining that. And We have just one final question, unless anyone wants to get in one extra question while I'm reading this one. But the last question we have so far is, microdeletions are fairly common overall. Shouldn't we be testing for as many of these as possible?
Yeah, so microdeletions has been the major driver of the use or moving away from chromosome analysis to using microarrays for invasive tests, for amnios and CVS. And the reason is because, as the questioner points out, they are pretty common. Although they're common, they are difficult. Some of them are characterized by very well-known syndromes and features like the 22q11.2 deletion syndrome. But a lot of them are really predispositions, situations where there's a lot of variability in the phenotypes associated with the deletions, susceptibility loci, and they're really quite difficult to predict or know what the phenotype is going to be in the fetus. So even for invasive testing, detecting microdeletions and microduplications is quite difficult. In the context of NIPT, well, nobody's NIPT will detect all of the microdeletions and duplications that an invasive test will detect. And the reason is that the vast majority of them are quite small segments, smaller than you could reasonably detect with cell-free DNA. There are some exceptions. There are some which are quite large segments that you could think about doing. And perhaps the most important of these is 22q11.2 deletion syndrome, about up to a 3.2 megabase deletion. Some laboratories have really specialized in being able to detect these, such as Natera's test for this. And they can be detected quite efficiently and well. So yes, detecting microdeletions, can be done, or a few of them can be done by non-invasive testing. And I certainly think it's worth doing 22q11.2 because it's a common disorder, it's serious, and it can be done very effectively. But for the other ones, they're rare. That means that the positive predictive values are going to be low. It becomes an individual consideration for each individual case, whether or not you want to offer that for those cases.
Thank you very much. So I think we've come to the end of our questions. So I just want to thank you again very, very much for spending time with us today to talk through all of these different issues and answer those questions for us. Thank you very much, Peter.
Thank you.